So during lab yesterday for class 196, we just had a little bit of a discussion about integration. And so I thought I would just share a few of those thoughts that we put on the whiteboard um, in a brief video, just in fairness, so that everyone's heard the same thing. There's nothing really groundbreaking here. All we talked about was one way you could start to get ready for integration. What could one approach look like? By no means do you have to use this approach. It's just an idea. But because 6 students yesterday had a discussion with me about this, I just want to kind of share it with everyone. And you can kind of take it or leave it, up to you. So we're gonna look at two pictures of things that I'd scribbled on the board as we were talking yesterday about ways you could prepare for integration. So this first one here, let me explain what each little stick person is about here. So one way you could do it is this. This is the way I would do it. I would first of all draw a generic diagram on a sheet of paper of this kind of the blue one, the one that says generic. Now what I would label this is I would label this generic one universal post-operative complications or universal complications that anyone who's bedridden on any ward for a number of days could face. And then I'd start filling in this stick person head to toe with everything that could go wrong in a hospital stay. And again, this could be for a medicine patient who's been in hospital for 4 or 5 days. This could be for a post-op patient. And as you can see, we filled in a couple, just some random ideas starting at the top. You could get delirium. Anyone can get delirium. A medical patient can get delirium from their medications, from their age, combined with being in hospital for so long. And there's many reasons. In fact, if you look at what's called a CAM assessment, a delirium assessment form, which all of your facilities should have, there's a list longer than my arm of all the different things that could cause delirium. So again, this is something that's common to all patients as a possibility of what could happen to them when they're in hospital. Another thing that we listed, and we didn't have a lot of time, so we just listed a couple, but another thing as we work our way down this diagram that we listed that could be possible for any patient, especially one that's not moving around enough, whether they're post-op or not, is the risk for atelectasis. And if you get atelectasis, that could lead to pneumonia. And you could keep going. You can constipation, DVTs, and there's probably quite a few things you could put on this diagram. So what I would do is I would draw this stick person that has and list off kind of all of the common complications that many different kinds of patients could face. So just think head to toe, what could go wrong neurologically? What could go wrong in terms of airway, breathing, circulation? What could go wrong in terms of GI, GU, integument, etc. One example not to forget is that any patient can fall. And we've covered falls in a number of times. We've covered it in Variations 4, and we've covered it in INP4. So falls, unfortunately, is something that happens to any patient. So it will be quite a busy little diagram once you're done, I imagine. There'll be quite a few things you could put on here. And I guess before I go on, I should say that when you come to integration, you are allowed to bring your notes. And so what I suggest is that you bring, when can you look at these notes? You can look at them before you go into the patient room. You're allowed to take one break from the patient room to come out and look at them again. And then when you finish assessing the patient and you come out of the room, if you need to sit down and look at them again, you can. So it's really useful to bring them in. And how I recommend you prepare them again is to have, I think we have 4 cases this time around, but whatever number it is, different cohorts have different number of cases. Let's say you have 4 potential cases that you could see this time around. Then I would bring in 4 packages, 1 package for each patient, because you don't know which patient you're going to get till you get there. And so when you're told you're getting, patient X, well, then you pull out package X, which has some of the things in it that we're talking about now. So one of the things that would be in patient X's package would be this generic diagram of a head to toe person with all the different labels of things that could go wrong. And we're going to talk about more about that in a second, but that's where I'd begin, is prepping that. And so if there's 4 potential cases, in each of those 4 potential case packages, you'll have the same picture, because again, all 4 patients could have any of these complications. Okay, then for each one of the cases, and we just did a couple, for example, started a couple, for example. For each one of the individual cases, I would do a separate stick person as well. And the only things I'd put on that stick person is the complications that are unique. And I should say, nothing is certain, but, that are most likely unique to that case. And I'll tell you right now, these purple ones, which are the cases themselves, you're not going to have a whole lot of things on here, because most of the things that could happen to these people are generic. So we didn't complete these, and don't by any means think these are complete. These are just the beginning, but we did a couple here, started a couple. Chad was one of the cases that were possible this time round. And Chad was a patient who had a background of COPD and a cholecystectomy, so gallbladder removal. So he had surgery, plus he had that medical background of COPD. And so we just came up with one while we were talking in lab. What's one thing that's unique to Chad that could come up for him that would not be likely to come up for the other patients? Well, a COPD exacerbation, for sure. That could be definitely something that could come up for him. So he might have, copious mucus in his lungs. He might have shortness of breath on exertion. In fact, these things could even be, I wouldn't say baseline, but could be, almost expected for him if he had a COPD exacerbation. So that's just one example. Now, we'd expect that for him. We wouldn't expect that for, say, Raj, who's another potential patient of yours this time around, who had an ileostomy creation. He had a hemicolectomy. Sure, Raj might have some atelectasis, so we should get some deep breathing and coughing going on, but we wouldn't expect Raj to have a COPD exacerbation, mucus production and all, unless he somehow got pneumonia. But, really, we can separate these things. We wouldn't expect this for Raj. And just the same, for Raj, who had the hemicolectomy, it's fairly reasonable to expect that he could suffer from paralytic ileus. Now, while it's reasonable to expect that Chad could suffer from constipation, as could any generic patient could suffer from constipation. So I wouldn't put constipation on any of these guys. I'd only put constipation on the generic, because every single patient in the hospital could suffer from constipation. But paralytic ileus itself, per se, not incredibly likely, generically speaking, not incredibly likely, for this guy, Chad, but really likely for the guy with the ileo. And so what you're going to end up with at the end of the day is as you begin these little packages that you're putting together for each of your, and you can include whatever you want in there. You can put variations notes in those packages. You can put INP notes, whatever you want. But what I suggest you include is in each of the 4 packages, this generic picture of the person with all the complications on it. And then in each package, the one that matches the patient that only has the complications that are most likely going to happen to them, that are possible for them. And those are unique. And I'll tell you right now, this blue one is going to be a pretty busy little diagram. But the purple ones, they're not. You're only going to find a handful of things that are really unique to these patients in terms of potential complications. Okay, then we move on to the second picture that we drew. And that's this one here. So now what do you do? So you draw those stick men, stick people, whatever, you draw those, the generic one and the ones for each individual case. Now, what do you do with them? I mean, that's great. You've labeled them. You've got complications listed from head to toe in each one of them. The generic one has a ton, and then each one specific to each case has a few. Now, what do you do with each one of those stick diagrams? How do you get more prepared? Well, we just used a generic one as an example, but you would treat them all in the same way. I should say you could treat them all. These are just ideas for you. This would work, for example, if I was studying for integration, this would work for me, but might not work for you. But what I would do is, so I'd take the generic one as the example, and we had listed a couple of things, delirium and atelectasis, just to start. I would make 3 columns, but hey, you could add on 5 columns if you want, whatever you want. This is just the start here. I would put labs definitely in 1 column. I would put nursing interventions in another column, and I'd put the medical interventions. And the medical interventions, just to put it in context of integration, is really about when I'm on the phone with the doctor and I'm wondering, and I want to suggest what the doctor should order, in my S bar, when I get to the R part, which is the recommendation. Here's what I think we should get, a chest x-ray, blood work, whatever. That's what I would list in this medical section here. So let me give you an example. Well, let's take something like delirium. Well, is there lab results that relate to delirium? There might not be. I mean, if you look at the causes of delirium, there might not be. On the other hand, there might be, given the context of the case, maybe increased urea, or maybe increased ammonia for liver failure. And that's causing hepatic encephalopathy. So that could be causing, well, that's not really delirium, but it is a form of delirium. But there might not be any labs. There might not be. It might just simply be, which is commonly the case, it's post-op delirium. The guy is really old. Heart surgery has this a lot. It's just delirium. You're not going to find a lab result that necessarily connects to that. So you'd put not applicable for that one. Nursing intervention, well, when it comes to delirium, I mean, there's delirium and then there's delirium. Some people are just pleasantly confused. And to be honest, there's not a whole lot of nursing interventions you can do, except, be kind and talk to them like you would talk to anyone else. Don't, contribute to their confusion. But if they're safe, they're not pulling out lines, and they're not getting lost on the ward, and they're not punching staff members, and there's really not a lot you can do as a nursing intervention. So I would just put maybe, safety ? Is my patient safe? For medical, so for that, I mean, if you look at like a delirium assessment tool, probably what's going to happen there is at some point, it's not necessarily an emergency, but at some point you're going to want to contact the physician and say, hey, I've got a patient who's delirious. I filled out the, whatever the CAM assessment. Here's the score I got. This patient's delirious. What do you want to do? And, you might suggest maybe the physician is going to want to order something like loxapine. Sometimes they do that, something like that. So maybe that's the extent of it. On the other hand, maybe you've got a delirious patient who is actually a safety risk. And so they're pulling out lines, or they're really combative. Maybe you do need that order for loxapine for sure. Then maybe it's more of a certain thing then that you need that. And the doc's going to help you out. Maybe you need an order, I hate to say it, but sometimes you need an order for restraints. And so you need to restrain the patient. Maybe combination of nursing thing might be, we need someone to sit and watch the patient. So you need to, as a nurse, you need to talk to the charge nurse, get them to authorize to get a staff member to sit there all day with the patient watching them. We do that quite a bit. So that's a bit of an obscure one, I have to admit, but that's kind of how you'd work the diagram, how you'd work these ones. Let's take something a little more straightforward. And in fact, I didn't list it here, but let's just take it straight off the bat, because it's a really common one, generic one that you're going to face, and that is low blood pressure. And we could flip it around and do high blood pressure too, but I'll kind of leave you here with the example of low blood pressure, which is super common, just all over the board. Low blood, especially post-op. So low blood pressure. Let's take that one. Say we put that down somewhere around the circulation level of the heart level of this little stick person. So we put, low BP. Okay. And by the way, you could do the same thing for high BP. It'd be a different exercise. But for now, I'll take you through low BP. So what are some labs that might contribute, that might be behind that low BP? Well, you want to fill in a few ideas. It depends what could be causing low BP. If it's blood loss, then I'd want to be looking at CBCs. I want to be looking at RBCs, hematocrit, hemoglobin. If the possibility is, and you want to anticipate all this. So if it's blood loss, I'm looking at CBCs, I'm looking at hematocrit, etc. Hemoglobin for sure. If I suspect that, no, another possibility in these cases could be dehydration. So then I want to look at things like sodium levels, for example. If I'm suspecting that it could be sepsis, which is a bit of an advanced topic, but we do cover it in our course, then again, you're gonna need to go through your variations notes to do this, guys. You're not gonna do it off the top of your heads. You go through your variations notes. That's why it's called integration. You're supposed to bring everything together. And I'm just providing one possible tool for you to do that with. So you go through your sepsis notes and you go, oh yeah, well, if it's sepsis, I should look at things like, did we do blood cultures? Is CRP up, or uh, um, if it's affecting respirations and they're breathing really rapidly or really slowly, do I want to look at ABGs, arterial blood gases? These types of examples are labs that you might want to include in there. We could go a lot further with sepsis, but that's a start for now. Certainly the culture and sensitivity. If the urine looks cloudy, we need that. Is that a lab example that might show up to contribute? Maybe it's a UTI that's turned to urosepsis. Okay, so that's the example of how you might use a lab column. Then the nursing intervention for low blood pressure actually might be, well, if my patient's dizzy, then safety is the key. I need to make sure that they're safe, they're not going to fall. It might be that I have to ask myself, am I okay to continue my assessment right now? Are they safe enough that I can continue the assessment? Or is this something that's like so urgent that I need to leave the room right now? Maybe you do, maybe you don't. But at some point in the case, just like in real life, you are going to leave the room. And at that time, that's when you're going to contact a physician. And that's how we put medical here. And you could even call us SBAR if you want. At some point, I'm going to have to contact the physician. And I'm going to explain the background, explain the situation, explain my findings, cluster my findings. And then what am I going to ask the doctor for? Because we're not going to sit there and give you the orders. You have to kind of anticipate what might the orders be. This is a sheet where you can organize that. So we listed a few examples of things that could cause low BP. So if it's blood loss that causes low BP, and we had lab values to back that up, maybe we want to get an order for a blood transfusion. Or maybe we might get away with getting an order for normal saline, because sometimes that'll do the trick. If it's dehydration, then we definitely want to get an order for a bolus. If it's sepsis and we haven't already got blood cultures, maybe you want to get an order. By the way, these labs could be part of the things you ask for. You could say, look, doc, we need to get some CBCs. We need to get some, lights. We need to get some blood cultures done. We need to get a few things here to try to figure out why we've got a low blood pressure. So you can kind of bring these labs into medical as something you might want to get ordered. We might want to order antibiotics if we think it's sepsis. You see how that works. These things can come into here. So the nursing intervention column is for anything you're going to do right away. Like while you're in the room, like for example, atelectasis, you're going to put the head of the bed up. You're going to encourage deep breathing and coughing. That's an example of things that happen in the room. That's a direct, immediate nursing intervention. The medical side's more of a bit of a longer term picture. What's the whole team going to do? You included, but really driven by the prescriber's orders. What are we going to do here? That's where you have to anticipate what's going to be ordered. What could fall into this column? We're including things like IV management, IV fluids, blood transfusion. We're even including things from this column. What lab work might you want to get ordered? That would go under here as well. So this kind of doubles up. The lab works as a source of evidence immediately available to you, but it might also be something you need to get ordered if it's not immediately available to you. So lab work, other diagnostics, maybe you want some imaging, medications, maybe we need some medications ordered, et cetera, et cetera. Just think, what does a doctor order? That would go in this column. If you're confused as to what that could be, go look at your variations notes, at those concept maps, and basically all of the circles in your concept maps are what doctors order in terms of diagnostics or in terms of interventions for treatment. So that's one way. This is just one possible way. And a lot of students do end up doing it this way, and they say it helped out a lot. They tweak these columns to fit their learning needs, and that's totally understandable. This is just off the top of my head, something I would do if I was preparing right now. But these are just ideas. But again, at the end of the day, you can come in with these packages. You can have the stuff already prepared. It can, you might not even use it much during a scenario, but I guarantee you having them in your hand will take a lot of anxiety off. And again, the value of integration is not the test itself. It's the preparation you did. And that is what students tell us year after year after year. So if you do something like this, whether or not you use it on the integration day or not is beside the point. You probably will. But even if you don't, the preparing of something like this is the process of integration. That is actually the integration. The integration test itself is a blip on the map. This is the actual integration. All right, I hope that helps, guys.